also speak on the acute care in ER and maybe in the ICU. So I
I
thought
think yours is
whatever latest is there,
I
let me
see.
compare.
Yeah, I because there from the beginning they kept saying that there'll be a lot of changes in the acute flare up, and they've got
Speak on the
that, and the clinical staging is uniform now,
Hmm.
the PRS and the PRAM, and also that earlier they would say that you don't do lung function tests in flare up. Now they say only in life threatening situation, no, but otherwise one must do a spirometry.
Hmm.
That even
So,
Sejal was talking when she was online, right? 2 days back. So she was talking of doing spirometries as they're recovering from an acute exacerbation before discharge, so as to do it before preventive inhalers are started.
and so it is to be done when they come in and at the time of discharge, because that is also when you strike the iron hot. And also the other mention is
Practically, I
document.
wonder whether it is possible. You try it, they will cough, and become really tough to do
But
it at
if
that
you
point.
see, Indu, if you do it, sometimes they have probably had a little rumble and the acceptance is poor. Like it's happened, or some children are on ICS, but the parents are still in some sort of a denial, right? But if they kind of see that reversibility, like I've had some of these, and I think once when Rashmi was talking on FOT, and they were doing FOT in flare ups, and seen it. Gina doesn't mention much on FOT at all this time. Last time it had still touched on in a few places. This time it just went on spirometry. And because I heard the podcast, they said that spirometry wherever possible, and otherwise at least you can use the peak flow, where I mean it's better than nothing. That was like the thing, but sh- an attempt for 2 weeks should be done. So it's I'll on the Gina.org, and then you say Gina podcast, Gina World Asthma Day, Gina podcast. You can hear there are three great talks, and the last talk on preventive primary prevention, that was very interesting. So it's great to hear people who've actually done 25,000 cases, and they've documented it and compared it.
I think we are already live streaming.
9 o'clock.
Yeah.
Yeah. So I think we still have to wait for Jayant and Narayan, or are they there, Manjuna?
Oh, Dr. Modi has very poor connection. He called me and said he may not be able to sustain the meeting. He was in
Okay.
a poor network area.
Okay.
And I have messaged Jain Joshi sir.
But for Subbu, all the speakers are there. Jayant has joined in.
So, good evening, sir.
Good evening, Dr. Manjunath. Good evening, everyone. Am I audible?
Good
Yes,
evening.
you're very much audible.
Yes, yes.
So it is 9. I think we will start our
Good evening, Jan sir.
Yes, good evening, sir. Good evening. How are you? Good
Fine.
evening, sir. Hello.
Hello, good evening to all.
Good
Good
yes.
evening.
Good evening, Dr. Jain. Good evening, everyone.
Hi, Indu. Yeah.
Hi.
Yes. Dr. Modi is here.
He
No,
has poor network.
Okay, then I think you can start. We will start with because it's already 9 o'clock. People have joined already.
Welcome, dear friends. It is World Asthma Day. this day is very important for all those people who have been practicing allergies and asthma, in whichever age wise they are practicing. Uh, it's a landmark day for every year for us because this is the day where we have the GINA guidelines released. It just not gives guidelines for the practicing pediatricians, physicians, and the chest physicians. It also gives a lot of impetus for the parents. How do we counsel them? How to give the measures for them to prevent asthma and to protect the children from having any serious issues. So with this, I request Dr. Jayan Joshi to give his opening remarks.
Yeah, good evening, everyone. Thank you, Dr. Manjunath, for the opening remarks. And I welcome all the dignitaries, all the faculty speakers who are stalwarts and who have been working for decades in the field of asthma. And I welcome Dr. Subramanya also, who has joined recently. So I think all of us, as Dr. Manjunath mentioned, are very much keen and very much interested in knowing about the latest guidelines about GINA, what's happening in the field of asthma. As you know, this is a problem which is global, which is worldwide, increasing trends, almost amounting to about 4.5 lakh deaths in children, even in today's era, in spite of all the modalities of investigations and treatment protocols available with us. So that's a sad state of affairs. Probably in the our part of the world, I think it is more appalling that probably we need to have a little improvisation in our health standards. So to learn more about this, I think I'm really privileged to invite Dr. Barnali, who is in the field of asthma for, I think, more than 3 decades now. And it is her passion, as what she says. And she has been the head of Casper. I would request Dr. Manjuna to introduce Dr. Barnali and also introduce our regulars, because most of the faculty speakers are well known to all the pulmonologists and all the gathering here. But still, as a protocol, I would request Dr. Manjuna to introduce Dr. Barnali, and I request Dr. Barnali to take over to moderate the session. Thank you very much.
Privilege to introduce Dr. Banali Bhattacharya. She is MD, DCH, and FRSTM H at London. She is a diploma in pediatric sleep medicine. She is a consultant in Pediatric Children's Clinic, Pune, and she is a consultant Asthma Care Children's Care, Pune. And she is the course director for Casper and Casper Clinics. So she's a master trainer for ATMs, and she's a member writing committee for ATMs in the previous years, and the under 5Vs in IAP modules. And she's a member writing committee for many of the IAP consensus statements and recommendation and air pollution and its effects on children's with allergies. So it is my greatest privileges to introduce Dr. Banali. I am so thankful to her to have taken up this responsibility of moderating this session for today. Thank you. And with this, please, Madam, you take over the session.
Thank you, Manjunath. Good evening, ladies and gentlemen. It's indeed a great privilege for me to be moderating today's session on World Asthma Day. A big thank you to NRC of the Indian Academy of Pediatrics for giving me this opportunity. All of you who are attending today's scientific session know that asthma is the commonest chronic disorder of childhood. But I want to tell you something more today. Some of you may have also read this article published 2 months back exactly in Lancet, which said that India contributes to 13% of global asthma burden. But hold your breath. Did you know that India contributes to 42% of global asthma mortality? There's a sharp intake of breath, right? And you're thinking, is that true? Can it happen? We need to accept it. We are in denial, just the way parents of children with asthma are in denial to accept the diagnosis of asthma. So once we accept accountability, we need to reboot our knowledge. So today's endeavor is one such that we learn a little bit more about asthma that we don't know, which will probably help us do our job better. There is a big spectrum from being normal to death. In that lies a lot of our children with jeopardized quality of life. You and me can together fight that. With this, I raise the curtain on today's scientific session. Ladies and gentlemen, we are extremely lucky because today we have a constellation of stars as speakers. Each one of them is committed to the cause of asthma, but each one of them is a teacher. They're either heads of department of pediatrics or they're head of department of pediatrics, director and intensive care, or they are leading a fellowship program, or they have been integral part of training program of asthma. So can it get better that we have 5 speakers who are all teachers? And a humble request to all of you. I know 10 minutes is short, but we have a long roadmap because after your 5, I will summarize it because people might join up late and they shouldn't miss out on what the first speaker said. And then we will have an open discussion because that is always exciting and it brings out sometimes the best bits. So, calling upon our first speaker, Dr. Indu Khosla. Now, to introduce Indu, she is a true go-getter in the right way. Whatever Indu targets, she achieves. She wants to do bronchoscopy, she learn, excel at it. She wants to do sleep, she will go into the rabbit hole and she will excel at it. So we are extremely lucky today that she is going to be our first speaker and she is going to talk about difficult to treat asthma and something that we are all hearing about a lot these days and know nothing about. And so she is going to educate us all about biologics. Indu, the stage is all yours.
Thank you, Banani, for those really kind words straight from the heart. And thank you, NRC, for giving me this platform. 10 minutes and biologicals is really difficult, but I will run through a few slides and try to cover as much as I can in the 10 minutes that have been allocated to me. So my aim of my presentation here is whom to give and whom not to give biologicals. And according to me, the second part is more important than whom to give. I will also look at pediatric data on when, which one, and for how long it can be given. And I would look at evidence for the use of biologicals in the pediatric population. So my first statement and my last statement would be most children with severe asthma do not need biologicals. And this, the GINA now, for look at adults and adolescents above the age of 12 years, if you look here, that what is new here is budesonide formoterol starting from step 1. And in the step 5, it is not oral corticosteroids higher up there, but biologicals after phenotyping these children who are in step 5 of asthma. The same is true for children with the age group of 6 to 11 years, okay, where they're referring to phenotyping and giving biologicals to that class of patients, right? And apart from giving biologicals for asthma, there are multiple inflammatory comorbidities in asthma where biologicals can be given. This is from up to date and anybody could refer, but there's a big list. For the want of time, I'm not going to go through it, but just to say, like for atopic dermatitis, dupilumab has been indicated, and for eosinophilic granulomatous polyangiitis, we can use mepolizumab and benralizumab. So there are a lot of other conditions as well, which are linked to asthma as comorbidities where your biologicals are now being indicated. So the first and foremost is we must differentiate between difficult to treat asthma. So I've just highlighted what is difficult to treat asthma. It is uncontrolled despite a prescription of a medium or a high dose. Wherein here there could be comorbidities, issues of adherence, issues of technique, and therefore it is difficult to treat, in the sense that once you address these issues, these asthmatics can be controlled without much ado. Severe asthma or severe therapy resistant asthma is uncontrolled despite having taken care of all these factors which normally we routinely see in our clinic, which are the reasons for difficult to treat asthma. So if you have taken care of all those and your child is having worsening of symptoms or few frequent exacerbations, that is the time where you really need to look for therapy beyond, and that's biologicals. And the incidence is about 3 to 10% of all people with severe asthma would be actually true severe therapy resistant asthma. And here, by definition, you need to have not only the dose of steroids, which are more than 800 micrograms per day, plus additional controllers, but there should be some functional deficit. Again, this could be in the form of an ACT less than 20, or requiring 2 bursts of corticosteroids, or severe exacerbations, hospitalization in PICU, along with this level of medication to qualify for severe asthma. So most of the unresponsive asthma we see, there are so many studies. The Jackie study published in Jackie in 2008, or in NEJM in 2010, finally where they thought it was difficult to treat asthma, adding on other molecules like azithromycin, LTRA, or a Badger study with higher dose of fluticasone. Nothing worked. All they said is keep it short, stupid, adherence, adherence, adherence. So that is again going back to saying that most people, you need to really look at the primary condition, look at adherence, and then take it forward. Now, this is a child we are currently with. This is a 5-year, 9-month-old female child with severe atopic dermatitis, rhinitis, and asthma. She was sensitized to multiple food allergens as well, but she had no aeroallergen sensitization. She had repeated exacerbations requiring 9 hospital admissions, 6 PICU admissions, monthly OPD visits, and multiple oral corticosteroids. She had 3 pneumothoraxes in an acute exacerbation with a pneumomediastinum. She had 2 episodes of anaphylaxis. One was to food and one was following vaccination. The parents were well educated, well read. We ensured good adherence, compliance, technique, and avoidance of allergen. Despite that, she kept coming back. So this is her investigations. I'm not really going to go through all that, just to highlight that her IgE was 116 when we first started. And then while she was on therapy, her IgE did drop down a little bit because she was on inhaled corticosteroids in a reasonably high dose, enough to qualify for severe therapy resistant asthma. The eosinophil count was up and down, and these are all the issues that she's had through multiple admissions. So her current medication is high dose ICS LABA. She was added on a LAMA, a diotropium. All her comorbid conditions were under control. Avoidance was followed, and still she came back, requiring multiple doses of oral steroids and admissions. Now, this is truly a severe therapy resistant asthma. So here, what do we do next? So there are multiple guidelines on how you must assess these kids, and how you must take them forward. You may have to assess biomarkers. You may need to find out what is the dominant biomarker. You may need to again evaluate comorbidities and other conditions like atopic dermatitis, which may also need which may also require biologicals. And then it has to be a patient and a parent and a doctor shared decision to decide what is to be done. Now, this is from Dr. Andy Bush's article, which he talks about bronchoscopic airway phenotyping, doing a bronchoscopy in this group of patients before going ahead. But is everything hunky and dory about phenotyping? The answer is no. There are limitations when you even have to do phenotyping, because severe therapy-resistant asthma is often eosinophilic, but there is no evidence to say that the Th2 pathway is at play in pediatrics. Peripheral blood eosinophilia may not relate to airway inflammation. Eosinophilia in our set of population may tell us a different story about the gut and parasitic infections. Sputum eosinophilia is not consistent with time, and you can have you can have a eosinopenic or you can have a neutrophilic airway. And this can change with time, and adult data cannot be extrapolated to children. And currently for pediatrics, we do not have an ideal biomarker. So this is a standard, a textbook picture of how at different levels biologicals can be used, right from the entry of the antigen or a pollutant or an allergen into the airway epithelium, where your alarmins, that is your IL-33, IL-25, and TSLPs get alarmed and then stimulate the dendritic cell, then the naive T cell, and it goes through the either the Th2 pathway, and where different biologicals can act. So right at the beginning, you have region 3500, which is still under trials, or you have tezepelumab. Then the most commonly used is anti-Ig, that is the omalizumab. There is data now on benralizumab, which was cleared for use in children above the age of 6. Dupilumab is also cleared for children above the age of 6 for atopic dermatitis, and about 12 for severe asthma. Mepolizumab, which has also got cleared for use in children above the age of 12 years. So you have a whole set and many more under trials at this point of time. I will talk predominantly more something on omalizumab to finish my talk, because that is something which is used most commonly. It is cleared for children above the age of 6 years. There are different guidelines, like as in the IgE levels in US and Europe, whereas in US it is between 30 to 700 units per ml is the cutoff for using omalizumab, whereas in Europe it is between 30 to 1500. Subcutaneously given once in 2 to 4 weeks. It's based on weight and the IgE levels. And if the volume of the medication is high, it may have to be divided into 2 sites. Okay. I will just go on to omalizumab. I'm going to skip this. Mechanism of action is anti-IgE. And this I already mentioned the dose. Now look at the evidence. Systematic reviews, 5 real-world studies, 3 RCTs, evidence of benefit with reduced steroid dosage usage in patients who are on omalizumab. There are real-world studies, 10 pediatric studies in children above age 6 years, better control, fewer attacks, and lesser use of ICS. 86 publications more showed improved treatment effectiveness, improved lung function, reduced exacerbations, reduced OCS use, emergency visits, and school absenteeism. In severe pediatric asthma, also there are 4 studies involving 1380 patients, which also showed reduced attacks and ICS. Most effective for step 5, reduced Th2 airway inflammation, and it also augments antiviral immune responses. So if a patient in a viral season gets a viral episode which causes asthma to occur, omalizumab will also help in controlling because it has an antiviral immune response. What about long-term data? There is studies up to 10 years where it has been used. So over a period of time, it definitely does not show any long-term side effects. But if you continue to use it, you have the effect. The moment you stop it, the patient may again go back to his initial presentation. This is the standard from a dosing guideline from a textbook, which you can refer to at any place. And Indians data, we have a lot of Indian studies where omalizumab has been used, but there is no prospective RCT or level of evidence specific to Indian children with severe asthma. So we definitely, all the data that we have is either a retrospective analysis or just a case cohort report. And so there is no prospective RCT. So we definitely need a multi-century registry or a study for our own population to understand the benefit of omalizumab in our population. Coming to mepolizumab, it is a monoclonal antibody against IL-5, and it also works on the eosinophils in induced sputum, or if it is present in the bowel. So it works on the eosinophils as well as it is because of the monoclonal antibody against IL-5. Blood eosinophilia is multifactorial. I will quickly show you 2 studies to wrap mepolizumab up. So this was the Muppets 2 study, where samples were obtained from only 53 participants. It reduced sputum eosinophils, it reduced blood and airway eosinophils, it decreased asthma exacerbation to the tune of 50%. All right. But they found that in the other 50%, exacerbation still occurred because there are different eosinophilic subpopulations. So you have the CD62 L intermittent and CD62 L high eosinophils, which continue to stay elevated. So all eosinophils are not bad. And if these continue to stay elevated, and they were responsible for exacerbation. So everything was not hunky and dory with mepolizumab. But what is important to see that there was a very small segment of pediatric populations where these studies were done. This study continued from 2024 to 2025 with 290 participants. Okay, so it also had concluded the similar way that about 50% reduction in exacerbations, and that was because of the eosinophilic subtypes which it did not target. The other drugs, benralizumab, again an anti-IL-5 receptor monoclonal antibody, cleared for use above the age of 6 years. The TATE study, which was done from US and Japan, had only 28 participants. And they just concluded that it is safe for use in children. And this came as a recommendation. Now, is 28 children a good enough number for us to say that this is a drug that can be used? The other drugs are dupilumab, dezilimab. Most of these are available today, but what we use most often is omalizumab, and we have with us mepolizumab, and most of them are not available in the country. Even dupilumab can be procured through the gray market, but it is not freely available. Now, dupilumab monoclonal antibody, it has two roles because it inhibits both IL-4 and IL-13, and it is licensed for atopic dermatitis in children about the age of 6 years. Again, small data in children, between the age of 6 to 11 years, 408 children studied in this article, which was published in the New England Journal. It worked for both atopic dermatitis and uncontrolled and moderate to severe asthma. It has to be given subcutaneously every 2 weeks. The primary endpoint was asthma attack. So it showed that it had better asthma control, and but it increased some minor infections. Again, we don't have long-term data. And efficacy was showed and maintained for 2 years. This is a drug which is again not currently cleared for use for pediatrics. It is only cleared for children above the age of 18 years, but it is helpful in Th2 low and Th2 high asthma. All right. Again, another drug, depemokimab. It binds IL-5 given every 6 months. The advantage is that this is a monoclonal antibody which need not be given frequently. It's once every 6 months. It's under trial for patients about the age of 12 years, currently recommended only about the age of 18 years. Attack rate almost halved versus the placebo. So my take-home message is get the basics right. First of all, is the diagnosis asthma? Are they taking the treatment properly? Technique, adherence. So most children with difficult asthma do not need biologicals. We have most data with omalizumab in children above the age of 6 years, and some data on mepolizumab and dupilumab, right? But insufficient data to recommend any other molecule at this point of time. Other molecules are still not cleared for use in children below the age of 12 years. We don't need comparison studies. We don't need adult studies. We need to have pediatric studies. We need to have Indian studies. So we need comparison studies and not only placebo-controlled studies to clear these drugs for use. Thank you very much. Lot of future research, more molecules coming in, but I'll stop here. Thank you.
That was a tough job done well. For most of us, they would be just tongue twisters and we would be stuck on the first line itself. But you took us through a lot of studies, Indu, and I will come back to you during our open house about this. So now let's move on to our next talk, and that is by Dr. Kishan Chugh. So if I say Dr. Kishan C, well, he's pretty much the big B of pediatric respirology in our country. And Dr. Kishan Chugh is not only, so he is, besides pulmonologist, an intensivist. And I think before pulmonology became what it is, like it is now pretty visible, he was known in the pediatric sector very much as a very, very efficient intensivist. So today we have him talking to us about ICU care in a child with asthma. Over to you, Dr. Kishanju.
Thank you. It's an honor to be speaking on this special day, the World Asthma Day 2026. And I have 10 minutes to talk about what can we do in a patient who's got acute flare-up of asthma and patient's already arrived in the PICU. And I'll talk a little bit about pre-arrival in the ICU. So since it's a long, big topic, I've decided to talk about just 2 points, respiratory support, and that also not go into the details of ventilation, and continued aerosol therapy during the respiratory support. That means if I put the child on HFNC or NIV, how will I still keep giving my nebulizations or inhalations? So we'll start with the case example and see how we manage this. This is a 9-year-old who had 38 kg, cough was going on for 1 week, fever for 1 day, fast breathing for 12 hours, initially managed at another hospital, was referred to us because of worsening respiratory distress. She was agitated, had nasal flaring, bilateral air entry was diminished, there were rhonchi, SpO2 was 76% only in room air, 84% when face mask was used. That means even on some oxygen, she was still hypoxic. Heart rate was high, respiratory rate was high, blood pressure okay, and nothing else. And this was the X-ray showing a lot of overinflation, hyperinflation. Now, as is advised, back-to-back nebulizations with levosalbutamol was given. She was too dyspneic to have been tried MDIs and such things. Hydrocortisone was given in the ER. Infusion of magnesium sulfate was started. She was shifted to the PICU, where by now her SpO2 had come to 92% with the best that we were able to do. Her CO2 on the venous blood gas was 43.7, which is high in this time indicates a bad situation for the patient. Because generally initially when the patient is trying to breathe hard, they wash out their CO2. When it comes to near 40, you're already on a bad stage, and anything above 40, it's a danger sign. And then 1 hour later, in spite of her best treatment, her CO2 had risen from 43 to 50. Remember, it's a ICU type of patient. That is why we are doing our VVGs. Generally, we probably don't do. And bicarb also had started coming down from 21 to 18. First part was that her agitation was worsening. She was very agitated, not allowing us to do much. So in such a situation, this is the algorithm that has been suggested by some, that first we give inhaled beta-agonist anticholinergic systemic corticosteroid, which we have done in our patients, with this all patient. Then second tier therapy is IV magnesium sulfate. This part we have done. Aminophylline we had not used. Salbutamol infusion we had not used. NIV or Heliox or inhaled magnesium sulfate, and these are the other options given by this algorithm. But this is where HFNC can be started. And the next point is, can we give ketamine and sedation or bronchodilation, because it is a bronchodilator? And should we intubate? When should we intubate? Those will be the next points of discussion. Of course, there may be a situation where you would intubate no matter what, because one of the indications of intubation has arrived, and I'll come to that. So first question, can we sedate this child? Yes or no? Okay, the answer is a no ordinarily. I tell my students, if you want to pass your exam, this is your answer. But if you are doing ICU, it can be used in your ICU if you are ready for mechanical ventilation. Remember, for putting a child on mechanical ventilation, we have to intubate. For intubation, not only that we have to use a sedation, we have to most of the times paralyze. So why be scared of using a sedative when you are in the ICU, where mechanical ventilation expertise is available, equipment is available? So we gave ketamine. Midazolam was not used. Ketamine is a bronchodilator. Sedation, it results in these advantages. It decreases the oxygen demand. Remember, agitated child, much more oxygen demand. It decreases the work of breathing. And there is a laminar flow in the airways. When there is a laminar flow in the airways, as shown below, there is so much less work of breathing compared to when it's a turbulent flow. an agitated child will have a turbulent flow. So ketamine infusion was started. There was no improvement noticed clinically and on bedside monitors. Next question is, should we consider ventilator support at this stage? And if yes, which one? So these are the possible ventilatory supports: HFNC, high flow nasal cannula, or humidified, high flow, heated nasal cannula. So this is first. Second is NIV, non-invasive mechanical ventilation, with that small ventilator kind of device that we have. Then mechanical ventilation with the full invasive ventilators that we use, and HFOV, high frequency oscillators. So which one is most suitable for asthmatic child? This as a traffic light strategy is suggested that if the respiratory status is like this, is suppose very severe, aims of treatment would be in this severe alternative to intubation. Do we have an alternative to intubation in severe patient? Non-invasive ventilation in a severe patient is not to be used. Standard medical therapy should continue all through, and invasive ventilation would be the only choice here in severe ones. Before that, non-invasive ventilation can be used, and HFNC is a new arrival which we must consider in our patients. Let's see what is the situation here. So this is a paper which says that from a physiological point of view, CPAP may reduce the burden on the inspiratory muscles related to autopy in a patient who's on HFNC. Use of heated and humidified gas also limits the bronchoconstriction induced by cold, dry gas that the child is otherwise inhaling through an oxygen source. Theoretically, high gas flow should improve the distribution of inhaled treatments. And HFNC for asthmatic patients seems attractive. This is the conclusion of this paper. Then acute asthma, we say that there is considerable experience with HFNC for this indication in our PICU, and HFNC use is freely used in our mild to moderate asthmatic attacks. In a very severe one, we would probably not give it a trial and move on to the next steps. But we must also remember that within 1 hour, our patient should improve or at least stabilize. If no, you have given enough trial, move on to the next step. We must also remember that initiating HFNC therapy worsens the respiratory distress in some patients. It worsens due to breath stacking. And what is breath stacking is this. In a patient who has a limited expiration because of asthma, each time is unable to empty out the lung, more and more volume keeps collecting. More volume means more pressure, and that is what is called the auto peak and expiratory pressure. That we didn't want it, and yet it has developed. So it is auto. This trapped gas will result in auto peak, and in such cases, workup breathing may actually improve with a reduction in the flow rate rather than increasing the flow rate. Now, overinflation is a non-uniform condition in patient because heterogeneous disease it is. It's not that all the alveoli are dilated and full of extra volume. There are some which are totally blocked. There are some which are partially blocked, which are just little blocked, and there are those which are totally open. When you give positive pressure from air by HFNC, CPAP, ventilation, whatever, this is what can happen. The one which is normal will overinflate to a large degree and may even burst, causing pneumothorax. This one is totally collapsed. Doesn't matter whether you give anything to it or not. This one traps more air. And this one also traps more air, depending on how much is the dilatation and how much is the constriction. So our patient, there was no change in status after 1 hour of HNC, neither clinically nor on monitors. So the question is, should we try NIV or shift to IMV directly? NIV will have these benefits. It decreases the need for intubation, improves alveolar ventilation, improves gas exchange, relieves dyspnea, decreases the workup breathing, resting of fatigued muscles, decreases the length of hospital stay, decreases mortality. This is on the basis of all studies that I'm not quoting here, but this is what it is. Now, how does it non-invasive ventilation works? This, whatever is here on the left side, all this is within the colors is the workup breathing. And when the patient is, this is in a normal person. When the patient has asthma, the workup breathing has gone to this extent on a spontaneous breath. When EPAP and IPAP are given, which is called NIV or BiPAP, then this is what happens. Workup breathing becomes so much lesser. So much gain from here to here is what happens when you give CPAP in workup breathing. So NIV trial can be given in patients only when, as a clinical judgment suggests that asthma is likely to respond to treatment within few hours. High workup breathing can be seen where breathing rate is high, accessory muscles are really being used, and obvious dyspnea is there. There is progressive fatigue getting worse. Patient has to be alert and cooperative. If the patient is already very agitated or going into sedative kind of effect, then we will not try NIV. Patient should be able to perform spirometry of PFR. Level 1 evidence says that this should be possible. Oxygen saturation should be more than 90% on room air. Level 1 evidence. Most of us do not start NIV at this stage. We would rather stick on to our HFNC. PCO2 should be less than 45. If it has already crossed 45, probably we'll lost that window. No excessive coughing or phlegm, because that will not
I'll
allow us to
reach home.
continue the NIV. No vomiting.
मैं तो यहीं बैठूंगी तो
Hemodynamic
11 बज
stability.
जाएगा मुझे.
Hemodynamic stability is something we must always remember. An unstable child who's vomiting and having a bad respiratory distress probably is not a candidate. Try only in carefully selected patients. Try only in PICU with highly trained staff. Monitor meticulously. I always teach my students that if you are the patient is NIV, probably you have to more meticulously monitor this patient than a one who's already been put on a full ventilation. Be prepared to intubate at the earliest sign of failure or deterioration. And remember, window of safety of opportunity is very, very narrow. And however, all said and done, it is worth a try in correctly selected patients. So unfortunately, no improvement occurred in our patient. Should we intubate is our next question. And if we are going to intubate, what are the indications? Let's see. So indications are absolute indication the patient is coma on a respiratory or cardiac arrest, no questions. I showed you the algorithm on the rightmost part of the algorithm. I said we'll jump off everything if one of these things have developed and go on straight away to ventilation and intubation. Relative indications are when there is cyanosis and severe hypoxia on maximum oxygen. Severe respiratory acidosis, PCO2 rising by more than 5 per hour. Deterioration, mental status getting worse. Silent chest, exhaustion. To me, this exhaustion is the single most important indication. We do not wait for many things to develop. If we feel the child is already exhausted and next few minutes is going to go into arrest, don't wait for anything else, just intubate. Now, when you have intubated or given HFNC or BiPAP, your bronchodilation has to continue, which has to be given as an aerosol. Now, how do you give it an aerosol? You put a child on ventilator. You can't stop the ventilator. There are techniques. Some of the modern ventilators have inbuilt inline nebulizations, possible, not as effective as this one. This is probably the best. Use a MDI through a cloud enhancer, which is just next to the patient. On this side is the patient endotracheal tube, and here is the ventilator. So this works best. Of course, there are various varieties of it. The collapsible one is probably a good choice. There are 5 places where the nebulizer can be put attached if the nebulizer has to be used and not MDI. Then there are 5 positions just at the humidifier that is next to the ventilator or very close to the patient, just 15 centimeters from the endotracheal tube, and there are some in-between positions. When the patient is on NIV, this is the patient here, this is the mask, and this is where the nebulizer can be attached. This is the Aerogen VMN nebulizer, vibrating mesh nebulizer. And this is the detail of the whole thing. Then evidence from modeling studies for HFNC says that this is the model that they had used, that there is a HFNC machine here. This is the so-called child or the adult being ventilated. And here is the ventilator, and here are the measures being made on the chamber. And what they came to conclusion was that when you use Aerogen with a ventilator, with a, HFNC device, this is where you can put just next to the HFNC or just next to the humidifier. But if the flow is very little, if you are giving very little flow, then it has to be just next to the patient. If there is small flow, you cannot expect the aerosol to go from here, and reach the patient. It does not happen. So it depends on the flow. One more additional point, that environmental contamination may have to be taken care of, because this child who has come may be exuding out RSVs and so on. So you have to be careful to protect yourself. And this kind of mask can be used for yourself, and on the child, you can put an ordinary mask over the nasal cannula, which is giving the HFNC. So that way we are protecting ourselves as much as possible. Thank you. I hope I have not taken too much time.
You couldn't have done better, and it also showed us that it's good to know asthma, but we definitely need intensivists, because we don't know which one of the ones with asthma goes down this way, and then it is pointless just holding on to primary care when we are doing the brainstorming. We'll come to that later about how the doses have all been altered. But I think it was brilliant. And what you showed us is, I think none of us around there could have done it. So thank you so very much for that. Thank you. So coming up next is Dr. Subramania, and Subu, as we call him affectionately. Now, he is a teacher who is all over. He will teach us cough, he will teach us pneumonia, he'll teach us x-rays, because that is what a teacher, when he studies, can know everything about the subject. So when he talks about asthma, or when he talks about the lungs, he is conducting all these courses because this is the way. And that's a great thing to learn from him, that before you teach, you need to know it well yourself. And what Dr. Subramania today is going to tell us is that all that wheezes is not asthma. And in the under 5 section, which Gina gave us last year, the second box, it has remained unchanged in Gina 2026. So though it was difficult for people to fathom, but that box is when no likely alternative cause. So he is going to tell us about all those alternate cause which wheezes and which is not asthma. So it's all yours, Subbu. Take it.
You are muted.
Subbu, unmute, please.
Subbu, you need to unmute yourself.
Yeah, okay. Now, am I audible now?
Yes, you are.
Okay. So, all that visas is not asthma. And thank you very much for for the invitation. And it's all about a visa. And is that visa an asthma or not an asthma? Now, in the first place, confirm that it is visa and revisit that it is visa. There are studies to say that some parents are very good and excellent in giving a version of a visa. And there are some parents who are poor at labeling a wheeze because they think crying, breathing, crackling, machinery sounds, difficulty in breathing, gora gora, blocked nose, everything that they could hear may be referred to as wheeze, and what you are referring to wheeze may not be. And therefore, always we prefer to have a physician confirmed wheeze, preferably an auscultation or by a very good mimicking and then the mother reconfirming. Basically, wheeze refers to a high-pitched musical sound of obstruction. I'm sorry for making it reaffirm because we tend and we do mistakes of mistaking it for stridor, stutter, snuffles, snoring, so on and so forth. What are the variants of the wheeze? It's all about number and the severity. And the first time wheeze is difficult to say whether it is what it is, but most often we assume as a clinical syndrome of bronchiolitis. And it is just we are under simple assumption that it doesn't recur as much as we expect, and it's often below 2 years because of anatomical narrowing of airways and epidemiological predilection of the viruses that you get a bronchiolitis. This is most common, and around 80 to 90% of our wheeze that we see for the first time belongs to only bronchiolitis. We have infrequent wheezers who wheeze little more than expected for bronchiolitis, but the wheeze for a couple of seasons and less than 3 is pretty normal, and these also overgrow with age and do not panic. Now I'll come to a phase where the patients wheeze quite frequently and more than 3 episodes. And here is a situation where it may or may not be an asthma. If you look at then, when the children walk into my OPD, can I recognize which one is asthma and which one is not an asthma? Mind you, it is just a toss and all pretty look similar. 1 in 10 could be an asthma by law of averages and prevalence of asthma, but it is difficult to identify. Now then, how do I approach? Now, first is that you define it is not acute or infrequent wheeze, but a frequently recurring wheeze. This is the first step. And what you are referring to wheeze as a wheeze. And in that wheeze, find out are they typical wheezers or atypical wheezers. If you leave out acute wheezers, etc., and take recurrent wheeze trajectory on follow-up, less than 50% continue to wheeze, and generally they have absence of disease. These are pretty well-looking children, and in contrast to atypical wheeze, which forms less than 5% of your wheezing practice, and there will be some identifiable cause, and there will be some clues which may be obvious or you might miss. And evaluation is based on smart pediatrician with good evaluation. Do a proper symptom analysis. My first problem with most of the pediatrician is they do not differentiate any wheeze into acute, recurrent, chronic, progressive, because there is a lot of overlap of symptoms in practice, and we tend to either hype or play down and do not take a proper history because we don't allow the mother to speak, and often we don't use our brain and heart axis properly, and often it is Tom and Jerry when we prescribe and then come back and look at the diagnosis. If you look at the origins of the wheeze, often if you look at the causes at the larger airways, then it is obviously more often a non-wheeze, and it is often a stridor, it is inspiratory, it is often monophonic, and often due to structural or persistent diseases. And sometimes you may see changes with positions, you may change with postures, you may see some changes obviously because of nebulization, intervention, etc. But it's very, very important for it to recognize this larger airway onset wheeze or origin wheeze, in contrast to a small airway disease where wheeze is more than the cough, and they are often polyphonic in nature, and the etiology is often inflammatory, and typically they are not fixed wheezes, but they are variable wheezes in intensity and severity. They are recurrent, and both of them can present as flare-ups, and that is the catch point. Often you see in outpatient or in the wards, the flare-up has to be uncovered, and then you have to see behind the presentation the appropriate diagnosis. That's most important. Qualifiers are most important for us. First, ask this question, which is most important: age of onset of the first wheeze. This is most important. A neonatal onset, early onset in infancy may or may not be an asthma. But on the contrary, it is also possible that earlier the onset, more likely to be differential diagnosis of asthma. Take a good history. And it's often the presentation that you mistake for diagnosis. Here there is a tricky situation, which is most important for us. Virus is both a cause of lower respiratory tract infection as well as a trigger for an asthma. And what is important, now within minutes, if you get the symptoms after viral onset of an URTI, that means it is a trigger. Or then you got a viral URTI and next day you have symptoms, it is possibly an evolution of the disease than a trigger. And this history is important. And hypoxia always happens little later in a viral lower respiratory tract infection compared to a trigger. And in a bacterial infection, on contrast, the evolution is much slower, and you will see hypoxia as a late presentation. Typically, you need to understand this presentation. Often it starts with fever, but symptoms do bang little later on. And this is typically post-infectious fever, post-infectious cough, wheeze, etc. And these are very common in viral infections in contrast to a bacterial infection. Remember, we need to separate an infection from allergy, and in under 5, infection is more common than allergy. And infection could be a trigger. That is tricky. And if you get a bacterial infection, then it is probably not an asthma. It could be a mimic like foreign body aspirations, congenital heart disease, etc. Never ever think of asthma in these situations. Wet cough, for example. Viral infections often tend to decline with the age, and they are febrile. There is a lot of anxious, over anxious parents, and there is an obvious history of a setting of epidemiology of viral infection. And that is when you will think of both asthma and no asthma. But if you have typical afebrile, allergic episodes, triggered episodic, then you have to think of asthma. Isolated wheeze without a cough or any other disease is probably something like a mimic than an asthma, because asthma doesn't exist without a cough. This is very, very important for all of us to understand. And when you do evaluation, you will often find cause. Many a times you need to revisit the history after starting the treatment, and foreign body is not there, foreign body is forgotten, foreign body is there when you don't think of it. That's very, very important. Do a proper analysis, ask for seasonal and diurnal variations. Here again, there is a tricky situation where, worsening at night can happen even in viral infections as well as in asthma. But the question that you have to ask is, the symptoms are in both day and night, and there is a gradual worsening by night, which is a feature of a viral infection, whereas typical only nocturnal coughs and wheezes are characteristics of a asthmatic flare-ups. And seasonal variations are also tricky on the same lines that I have told you. Now, qualifiers for trend of the wheeze is very important. Don't worry to jump to diagnosis at the point of time. Over a period of time, you are likely to make a diagnosis of what a wheeze is, an asthma, or wheeze unlikely to be an asthma. If you see here both the tables on to my left, what you are seeing is that the wheezes and coughs increase with years, first year, second year, third year. It keeps on worsening versus it starts reducing. You might have seen many patients in your practice who don't visit after they have troubled you in the first couple of years. You may be wondering they have gone to the neighboring pediatrician, but actually you will come to know that they were transient wheezers. You are very happy when the same mother comes back with the second kid and again starts with the history of wheezing. This is transient wheezing, very common in practice. You need to identify it from progressive, increasing, worsening episodes of wheezing, which is very common of asthma. Now, response to bronchodilator, it is the quick, predictable response that is important, not the response on third day, fourth day, fifth day. And response to an antibiotic is not an evidence of infection. Response to inhalation corticosteroids can be evaluated as a trial of therapy in inhaled, or quick response to an oral dose of prednisolone, if you have given, would also suggest probability of asthma. Many a times the clues that gives rise to alternative diagnosis or a probability of a non-asthma are very obvious. There could be a failure to thrive, a sick child, febrile child, and you might have missed a murmur in that gora gora.
Have we lost Subbu?
Yeah.
Maybe some network issue.
Parents are anxious.
Yeah.
If pediatrician is a beginner and anxious, if there's a troublesome cough, if there is
Subbu,
pharmaceutical
excuse me.
pressures.
We had
Yeah,
lost you for 30 seconds. You can go back to the previous
I
slide.
lined up.
No,
If there
no,
is
go
home,
back. No, just hold on. We lost
yeah,
you for 30 seconds. Go back to your previous slide because we couldn't hear you.
okay. Am
Yeah.
I audible now?
Yeah. Start this slide again.
Okay. The point is
Not
that
this one. Yeah,
sometimes,
this one.
yeah, sometimes the causes of the wheeze may be obvious by looking at some clues which we may miss. And there can be a child with failure to thrive. There could be a normal looking child but sick, febrile, and there could be a clubbing that you miss. And many times I've missed a murmur, and localization on examination is very, very important. These clues could be obvious, or sometimes they may be subtle, and you need to pick them up. And these recurrent wheeze can look like asthma, but may or may not be asthma. And sometimes it is more often not an asthma than being an asthma. And that happens when parents are anxious, when the pediatrician is a beginner in practice, and when the cough is troublesome, when there is home nebulization, and when there is pharmaceutical pressures. These are the situations in which, overdiagnosis of asthma is possible, and they are not to be taken as mimics. Underdiagnosis is possible when you don't want to label a patient of asthma as an asthma, and there is a mother who is telling us something and we don't pick them up, and this is very, very important for us in practice. Be assured that most children are normal, but think of common, because common things are more common than rare things. The most common cause of recurrent wheeze is an asthma, irrespective of the age. However, all that wheezes is not asthma. This forms a small fraction of your patients. logical approach could be take a careful history, do a good examination, identify the red flags, make a diagnosis. If the diagnosis is incorrect, it will be obvious on examination. Do investigations wherever possible. Investigation should be directed by history, not a battery of investigations. You may have to do high-end evaluations for that wheeze which is not an asthma, like bronchoscopy, CT, laryngoscopy, as per the need of the child. And trial of therapy is always worth doing, either with salbutamol or with 12 weeks of inhalation corticosteroid. I'm summarizing it for you. This table is pretty simple. If you have not listened to me, it's okay. Now you can carefully listen to me, and this is all that you need to know. Evaluate the child, evaluate the wheeze. If the wheeze is typical and the child is normal, generally it tends to overgrow. If the wheeze is typical and child is abnormal, you don't worry about it, evaluate. If the wheeze is atypical, and even if the child is normal, evaluate. It could be a foreign body. If the wheeze and child are both are atypical and abnormal, there is no choice but to evaluate. This is a pretty simple table that will help you to make a diagnosis of alternative diagnosis. Remember, recurrent wheeze in your OPD could be an asthma, but may not be an asthma, but it's all about evaluation that you need to do. Analyze airway narrowing properly. If you look at the canal of Hermosa, you would feel what is the cause of this narrowing.
Subbu,
You may
you've
see,
overshot. God,
no, yeah, I'm in 30 seconds over. This is the last slide.
cool.
If you see the narrowing of airways, then you may think the cause is most common, but there could be some hidden causes that needs some more exploration. Lastly, think of common causes, expect the unexpected. And therefore, cheers to you, and always think beyond what you should do. And normal is an exclusion of abnormal. All that wheezes is not asthma. And over to you, Barnali. Thank you.
Thank you, Subbu. Some things don't change, just
Yeah.
as our belief that all that wheezes is not asthma, and Subbu ending his slideshow with Aishwarya Rai.
Loyalty.
So, yeah, true. So true loyalty to the science and true loyalty to your sweetheart. Okay, now let's get on to the next one. So the next talk is by Dr. Shishir Modak. Now, all of you who attend asthma symposiums or asthma conferences all relate the GINA moderation. Nobody does it better than Shishir. And I have been part of his panel many a time, and he works much harder than all of us. He will study, study, study. He'll prepare. He will put in the answers also up there for us to read. And so then the audience is busy taking those pictures because Shishir has done the work for the audience, the panelists. But he is absolutely, that is his methodology, detailing. And that is why he probably wrote the asthma training module once. And also one of the modules that doesn't exist anymore, the under 5 V's, was a brilliant module of the central IIP, which he wrote. So with that, Shishir is going to tell us something very important. So yes, we start, and then our parents keep on at it, and then we don't tell them that dangle that carrot that I'm going to step down, and then they stop it on their own. So there is a complete science to stepping down therapy in asthma management, and we have Shishir to tell us about it. Take it, Shishir, all yours.
Thank you, Barnali, for those kind words. I'll start sharing my screen. Are you able to see my slides?
Yes.
Yeah. Very good evening to all of you. It's really my honor to be here on World Asthma Day as a speaker. My topic is stepping down therapy in asthma management. It is really a short topic, and I'll definitely finish in less than 10 minutes. So why step down? The first question is why to step down the therapy. So obviously, if we are giving medium dose or high dose treatment, particularly inhaled corticosteroids, then the side effects are there when you treat it long term. So to minimize side effects and to find out patient's minimum effective treatment to achieve good control over symptoms and future exacerbations. So we should not lose control even after stepping down. Control of asthma should not be lost, and there should not be any exacerbation. This is the basic principle. And that should be achieved by minimum effective dose. And of course, to minimize the cost of therapy. So stepping down is essential in any asthma management. Then when to step down? Once we have decided we need to step down, and when to step down the therapy. So once good asthma control is achieved and maintained for 2 to 3 months, not in 10 days, 15 days or so, which is commonly done in practice. So good control is well controlled. All of the pediatricians know the criteria of level of control. So all those criteria should be met and child should be well controlled for at least 2 to 3 months, and then only one should think of stepping down. What happens is lung function reaches a plateau. So once the child has improved and child is asymptomatic, FEV1 doesn't go on increasing after say few months, and therefore there is no point in continuing high dose or medium dose at that point, and so we should think of stepping down the therapy. Now, when to step down? So there are certain advices. That is, there should not be any respiratory infection. There should not be any particular season where the child is prone to get symptoms. For example, in our country, it is monsoon season or winter season when the children are more prone. This month, where World Asthma Day falls, that is month of May, it is the best season for asthmatic. There are least number of patients of asthma, and this is a dry and summer season is a good season. So in this season, one can think of stepping down treatment, not in monsoon or not in a season where the child is more susceptible. Child is not going on vacation because there should not be any emergency after stepping down when the child is out of station. So these are few advisories given for stepping down. But the basic principle again is there should not be any loss of asthma control after stepping down. Now, what are the risk factors for loss of asthma control? So history of exacerbation or emergency room visit or hospitalization in last 12 months, that is a risk factor. Then low baseline FEV1. If FEV1 was very low, less than 60% to begin with, then that child is also at a risk of recurrence of symptoms. High sputum eosinophilia. So T2 high subjects or T2 high children have more chances of recurrence after stepping down. And any treatment step down should be considered as a therapeutic trial and also while stepping down. We all know that what is a written asthma plan. So what is the current treatment? What should be done if symptoms increase? What should be done if there is acute flare-up? The contact number of doctor or clinic, and what medicines should be started or what inhalers should be started, how they should be increased at home. So all that is written in asthma action plan, and that should be explained to the parents and given it in writing. So some general principles about stepping down. We are talking and we will discuss guidelines and the way it should be stepped down. But actually, data is limited about optimal timing, sequence of stepping down, magnitude, how far it should be stepped down, particularly in children. There are not large trials of stepping down, but this is mainly by consensus. The treatment step down should be individualized because it depends on whether it's a severe asthma, whether a child is on step 5 treatment, step 4 treatment, and also if the child has the risk factors which we have discussed, and if the child has some other comorbidities. So all these factors should be taken into account while stepping down, so that stepping down of treatment will be individualized treatment. If treatment is stepped down very fast, very rapidly, or very quickly, then there are more chances of exacerbation. Now, whenever we are stepping down and if the child is on ICS and LABA should not be stopped. ICS dose should be reduced because it is observed that if LABA is stopped, there are more chances of exacerbation. Then complete cessation of ICS is not advised, even if the child is well controlled. Particularly, that is this recommendation is for adults. In adults, they say that one dose of ICS at night time should always be continued. There should not be total stoppage of ICS. And in children, of course, we stop because of the fear of side effects. Then as needed budesonide and formoterol inhaler is better than low dose ICS plus SAVA. So instead of keeping the child on low dose budesonide plus any other LABA, it is better to use budesonide formoterol as and when needed. So these are the general principles of stepping down of treatment. Now we go to step by step. So in step 5 treatment, if oral corticosteroids are started, try to reduce OCS because of its side effects. So OCS should be reduced first. Optimize ICS to reduce OCS. So you can increase the dose of inhaled corticosteroid. You can go to high dose. It is better than giving prednisolone or oral corticosteroid. Use sputum guided approach. Nowadays, for any severe asthma or for step 5 treatment, phenotypic assessment is usually done. And from that phenotypic assessment, you find out that whether biologics can be started, as Dr. Indu has already dealt with. So biologics should take precedence over oral corticosteroids. So wherever possible and affordable, if the child is eligible for biologics, that should be started first, and OCS should be a last resort. If the child is already on OCS low dose, then make it alternating. That's how you can reduce the side effects. Now, how biologics should be stepped down? There are no clear-cut guidelines, as the minimum trial is for 4 months, but at least this biologic should be continued for 12 months and beyond. In less than 12 months, biologic should not be withdrawn. And it is observed that even if you give biologics for years together, when you stop biologics, there are chances of exacerbation in many patients. So many patients who have been given biologics, they also can recur, the symptoms can recur and child can relapse. So that is about step 5 treatment. Step 4 treatment, see, mind you, every reduction is continued for 3 months. Means whenever we are reducing the dose, that should be continued for 3 months. If on budesonide plus formoterol in step 4 child, older children particularly, or even children above 6 years, they can be on MART, so budesonide formoterol. So reduce ICS dose by 50% and make it low dose. That means if there is 400 microgram twice daily budesonide, then make it 200 microgram twice daily. In our ATM, we say that it may be 25 to 50%, but GINA usually mentions 50% only. So reduce the ICS dose by 50%, continue it for 3 months and make it a low dose. If child is on ICS plus other LABA other than formoterol, then also reduce ICS by 50%. So again, make it a low dose. Don't stop LABA. First, reduce the dose of ICS till you reach the lowest dose. Until then, don't stop LABA because stoppage of LABA leads to deterioration. Now, coming to step 3 treatment, if child is on MART, that is budesonide formoterol inhaler, reduce maintenance dose of budesonide formula to once daily because already child is on low dose. So then you cannot reduce it further. So you can make it once daily. Particularly budesonide can, even fluticasone can be given once daily. But since we are continuing with MART, so MART is budesonide plus formoterol. So that should be given once daily. If on ICS and other LABA, like salmeterol, reduce low dose ICS LABA to once daily. So once daily is the option. And reduce other controller drugs. For example, if child is on LAMA, that is tiotropium, or child is on montelukast, so those drugs also should be reduced at this stage. So that is stepping down of step 3. Now coming to step 2. In children about 12 years, if child is on track 1, as you are aware that step 1 and step 2 is combined in track 1. So as it is, child is on as per need budesonide formoterol. So you cannot reduce it further. So keep that child should be on budesonide plus formoterol as and when required, whenever child gets symptoms. If the child is on track 2, that is budesonide and salbutamol as a reliever, then low dose maintenance budesonide should be the stepping down treatment and salbutamol as and when required as a reliever. But remember, this track 2 is a bit dangerous track because Here there are chances that when the child is getting very infrequent symptoms and child is well controlled, there is a chance that child will not take budesonide and child will use only salbutamol. And at any cost, we should avoid salbutamol alone treatment. It should not be used as a reliever alone unless there is ICS. So whenever salbutamol taken, there should be always ICS. In children 6 to 11 years also, if the child is on step 2 treatment, make it low dose maintenance budesonide, that is 100 microgram once a day. So that is if the child is on step 2 treatment. Now, further reduction is step 1 treatment, but we say that it should be brought down to age appropriate step 1 treatment. So in children about 12 years, age appropriate step is low dose budesonide plus formoterol combination inhaler as and when needed. Then track 2 is ICS taken whenever SABA taken. So whenever salbutamol is taken, budesonide should also be taken. So much so that in Trexa trial, both these inhalers were tapped together. So moment one inhaler of salbutamol is taken, one inhalation is taken, immediately ICS also should be taken. And in India, beclomethasone plus salbutamol inhaler is available as Aerocort that can be used. But if you want to use budesonide, you'll have to use two separate inhalers in children who are on track 2 and even in children 6 to 11 years. ICS taken whenever SABA taken, that is the step 1 treatment and that should be continued, right? As a final step in stepping down the therapy. Now, there can be some other strategies. Up till now, we have seen the guidelines, what guidelines suggest, but there can be strategies based on biomarkers. But the problem with biomarkers is this sputum eosinophilia that cannot be found out unless the child is in tertiary care center. So unless you do BAL, you will not be able to know sputum eosinophilia. And FeNO also, in many trials, FeNO-based treatment decisions in adjusting asthma therapy did not make significant difference compared to guidelines-based treatment. So whatever we discussed earlier, the treatment stepping down on the basis of guidelines is good enough for all pediatricians, particularly general pediatricians, and this FeNO-based or sputum eosinophil treatment is only possible in higher centers. And biomarker-based treatment adjustment is more required for stepping up treatment rather than stepping down. Because in stepping down, you know that child is well controlled. So there is no need to do biomarker-based stepping down.
I
Now coming
request
to
you to
under
step
5 years.
down now.
Yeah,
Shishir, you'll have
yeah,
to wrap up
last
fast. Yeah.
last two slides. Stepping down therapy in children under 5 years is special. Under 5 years is a special situation. So suppose we are giving trial of ICS to confirm the diagnosis of asthma. Then we start with budesonide 200 microgram twice a day for 2 to 3 months as per GINA 25 and also 26 guidelines. If there is good response, then diagnosis of asthma is confirmed. Once the asthma diagnosis is confirmed, we give step 2 treatment, that is low dose budesonide 100 microgram twice daily for 3 months. And then after 3 months, previously we used to say that you stop abruptly and let the symptoms recur and call the child if the symptoms recur. But these latest guidelines say that it may be reduced to budesonide 100 microgram once a day. So slow reduction as in older children. So once the diagnosis of asthma is confirmed, you can reduce it by making it 100 microgram once a day for 3 months and then stop the treatment. So my final advice is if possible, spirometry should be done before finally stopping the treatment wherever possible, particularly in older children, of course. Written asthma action plan should be explained and given to each patient and should be explained to the parents. Appropriate inhaler should always be readily available, handy to the child at all the times. Because what happens once the treatment is stopped, there are no inhaler at home, and suddenly if there is flare up, there will be problem. Child will land in trouble. So inhaler should always be there at home, and even if child goes on a picnic or trip or vacation, the inhaler should be with him. Parents should be told that the child is well controlled but is not really cured, and parents should be asked to report immediately if there is recurrence of symptoms. Controller treatment needs to be restarted if there is recurrence of symptoms. Parents should be asked to follow up every 2 to 3 months for 1 year, even after stepping down to the step 1, and maybe less frequently later on. In any case, child should remain well controlled and should be able to perform the activities, all the activities, even if treatment is stepped down. There should not be loss of control. Thank you. Thank you very much.
Like I mentioned, Shishir is detailed, and he said that it's going to be a short talk, but he took us to everything so judiciously, and that is exactly what I said. Because when you know people long and you know their strengths, and he showed it, and I was trying to grab him to stop, but relentlessly he went till he got us down to step down and only reliever SOS. So, coming to our last talk, and this is a very, very important talk. First, let me tell you about Dr. Kalpana. Now, earlier we used to only know him about his indoor allergens. And, we used to look out as to who's this person who knows so much about indoor triggers. And at this point of time, he's also known for the body of work that he does in FOT. And I was wondering, when NRC gave him this talk on obesity and asthma, that is it his fondness for FOT, because he's actually seeing small airway diseases, but obesity is an epidemic. And it is now one of the very known comorbids in asthma. So, this is going to be a talk which is going to educate and open a lot of windows in our mind. So, over to you, Dr. Kalapanawar. Please take it.
Thank you. Thank you, ma'am. Respected President and all the office bearers of Iapnrc, my seniors, thank you very much for this opportunity to share the podium with the stalwarts. And I'm sure today my talk is on obesity and asthma. Believe me, this is a really tough job because, where there is many things to say, but very short time is been given. And let me see how best I can cover this. To begin with, as already Madam told us, the epidemiology about obesity, it is increasing, and it is increasing in both incident as well as prevalence. Very interesting fact is risk increases almost 1.32 times when the body weight increases 5 kg per meter square in BMI. And bidirectionally, asthma in early childhood increases obesity twofold by age. That means younger the age, if he is obese, and there is a high chance of getting asthma. And asthma in obesity is often severe, and it is refractory to our standard, whatever guidelines so far has been mentioned by other speakers. So this is the beauty of obesity. And regarding obesity is concerned in Indian scenario, if you see that the National Family Health Survey, 4 was telling it is 2.1%, but it has increased to 3.4%. And not only that, even in urban, it is challenging because in most of the metropolitans, it is increasing, and both metabolic non-communicable disease. And it is a double burden because the stunting is coexisting with overweight. We all know that what happens to the lung functions in stunted people. Next is, even in Indian data, look at that. It was showed that almost from a National Family Health Service 4 to 5, it has increased to 60%. That is from 2.1, it has gone to 3.4%. And simultaneously, it is regional variation is also seen. If you see this double burden, that is, the stunting is coexisting with obesity. In Delhi, it is 13.6%, whereas in Arunachal, it is 17.9%. That means there is a huge shift in urban areas. And if I talk about physiology, why it is different, if you see the comorbidities with asthma, but it is also challenging for one who is treating asthma in obese. You have the pathophysiology, then you will realize why it is difficult. And if earlier they told no, you see that look at the comorbidities, and it is always challenging in obese child. These are the four reasons, and these are the pathophysiology changes which make difficult for anybody to treat asthma in obese. One is mechanical, the mass loading, which reduces the volumes of lungs, and another one is structural, the airway dysynapsis. I'll come back to that. Metabolic and endocrinal and immunological changes. These four mechanisms makes the obese children different than a linear children with asthma. What happens in mechanical pathway? The adipose tissue, which is on the chest wall and abdomen, it tend to reduce the functional residual capacity. And that is most important for any child to have a good ventilation. Impact, the breathing at a low FRC increases airway reactivity, and thereby they become more severe and loss of radial traction on small airways. And this leads to airway closure. This is more air is trapped because of this mechanical pathway. What happens in anatomical? Dysynapsis means the lung parenchyma is increasing, but proportionate airway is not increasing. That is what is known as dysynapsis. So thereby what happens, the ratio between FEV1 to FEC, it lowers. But if you take an absolute value of both FEV1 as well as FEC, they are usually absolute values are normal, but the ratio tend to be, the lower. And that is what is the commonest condition. And these structural dysynapses will have higher insulin and severe wheezing. And best example is in case of, obese children. Third thing is endocrine. What happens? Adipose tissue is an active endocrine organ in the body, and it releases a lot of pro-inflammatory mediators. They are called as adipokines. What these adipokines help is, these adipokines, anti-inflammatory, their reduction is removes the protective airway effect. That's why the airways tend to get more hyperreactive. Whereas leptin is a pro-inflammatory and which promotes the airway hyperresponsiveness. And that is what happens in obese children. Look at the other metabolic changes which happens in obese are interleukin 6. You have seen the biologics, and this is the one which will be high circulating levels in obese children, and they creates a systemic pro-inflammatory environment, and thereby these children usually will have classic T2 high asthma making standard inhaler. But oxidative stress, it is a late onset obesity wherein asthma shows increased systemic oxidative stress, and that is why it becomes more difficult to treat. And similarly, insulin resistance also. And these children impair the bronchodilator response, and which accelerate the lung function decline, as well as it is the low lung functions, and that is why these children will have a severe manifestation. And another important thing is immunological shift. If you take the innate lymphoid cells are nothing but the protective cells in the body. They are also called as immunity cells, and they are the one which are usually a lot of help in the maintaining immunity of the airways. And these innate cells and becomes independently acting. And type 1 shift, that is usually pediatric obese children related to asthma, is often Th1 dominant rather than Th2 dominant, because Th2 dominant is usually early age and they are eosinophilic. They respond better to your steroids. But here it is Th1 dominant, they becomes more, and the child gets obese and adolescent. And neutrophils, as I said, it is more of a neutrophilic infiltrate in these children. And what about oxidative stress? As I said, there is a very important, the oxidative stress which impairs, that is histone deacetylase. And this histone deacetylase, when it is impaired, which usually prevents corticosteroid from switching off inflammatory genes, leading to steroid resistance. That is why ICS doesn't work in these children. And mitochondrial dysfunction in adipose tissue leads to release of lot of peroxide nitrates, and they further damages the airway epithelium, and that is also reduces the your steroid effect. So these two important shift that causes steroid resistance in case of obese children. And if you see them, this is very important chart wherein a asthma complicated by obesity and another one is asthma is a consequent to obesity. If a child is less than 12 years, it is a complicated by asthma. Obesity is complicated by asthma. There it is eosinophilic and airway response to your steroids. Whereas if it is a consequent to obesity, usually happens in more than 12 years of age, and it is T2 low and they are small airway dysfunction, they are often non-atopic. So there it is very difficult to treat with your ICS. Second thing is, look at obese children. As I said, usually it corresponds to the age. What is one more thing, important thing is the waist circumference. So better correlate with the metabolic dysfunction. Whenever there is a waist circumference is more, they are usually metabologically unhealthy children. And if this right side chart will show you what happens if the younger the age, the BMI is more, it falls more than 95th centile. So that is why it is the waist circumference. It is similarly bad to even cardiac patients because the highest chance of MI is more common with the waist obesity. And similarly, waist obesity will disturb metabolically, and all whatever metabolic shift I told, they are more prominent in case of waist, obesity. The obesity around the trunk is very bad for these asthma children. And what about clinical features? I don't go in detail, but I will tell you certain things. The obese children tend to have more breathlessness because they increased oxygen cost, the higher rate of perceived exertion, and the deep conditioning from sedative behavior. Most of them are usually sedative. They don't participate in active, child playing. And what happens if you do the spirometry or lung function test? This is what I told in the initially. The baseline FEV1, FEC may be normal, but the ratio is usually reduced. That is what is called dysynapsis. That is what I said. The lung parenchyma is proportionately hyperplasic, but the airways are very small and they become a bottleneck in these children. So bronchodilator reversibility is often blunted. It is usually misdiagnosed as fixed airway obstruction because of this dysynapsis. And peripheral airways, as I said, best to pick up with the FOT. And FOT is a just you can perform in any child even under 5 years because it is just effortless, and usually it is a tidal breathing and it measures the small airway better than spirometry. And here what happens is, as I said, here both resistance and reactance both will be increased. That is why, and you can easily pick up small airway diseases. And the reversibility, as I said, here also it is blunted and you don't see the expected amount of reversibility in these children. And the GINA also says the pheno updates, the adipose indicates are inversely related to the pheno levels, but they can looks normal in obese children. The proposed threshold is much lower because the guideline says that if you have in a normal child, the pheno of more than 25 and more than 35 is definitive. But here, even the pheno level of 15 is also clinically significant in case of obese children. And the beyond evaluation, as I said, you can see here the ratio, as I told you, the pheno less than even 15 becomes significant. The reversibility, as I told, they are blunted in obese children, and eosinophil higher submucosal, lower in sputum, and it is not eosinophil mediated inflammation. To finally say that the comorbidities one has to be always think in case of obese children is obstructive sleep apnea, And it is well said, it goes hand in hand, and invariably it becomes very difficult to treat if you don't address the obstructive sleep apnea. It is also a source for obesity, and it is a cause and the effect in obese children. And similarly, other two important things are GRD. So GRD, because abdominal pressure increases in obese, and that triggers reflux, and as well as it increases the symptoms of asthma. And metabolic syndromes, as I told you, insulin resistance is well known, and interleukins are plenty, and they causes bronchodilatory effect blunted. And comorbidity, last one is psychological. And if you see the GINA, you know that it is one of the modifiable, the parameter for controlling asthma. It is very common with these children, and they are the one will create lot of problems. And all the more the peer age is effect on the psychological effect. So to diagnose, as I said, usually you will get differential diagnosis. Very difficult to is vocal cord dysfunction, and majority of the time large airway compressions, they can cause fixed airway reversibility, and the dysynapsis is the one which will give us. So just two words about the management aspect, and it has been already said, nearly all patients require definitely ICS, and preferred track, it was already said. And obese children often requires higher steps, because I already told why these children are ICS resistant, and what could be the other comorbidities with them, and metabolic derailments, all has to be addressed, not just stepping up the treatment of asthma in G children. And the same standard stepwise management for asthma too in obese children. But only thing is, you will have to make sure the best way to reduce or get an effect is the have a good control over the weight of the child. And as the weight reduces, it becomes significantly responsive. And I will tell you that about the another important thing. So other things, and already madam has told about all these biologics. And one of the case in difficult asthma is obese children with asthma. And in them, after ruling it is all the difficulties in adherence, dose, drugs, duration, everything. And please look, this is very challenging, and wherein we can use these biologics, and they have been proved beyond doubt they are going to be help in them. And this already, this slide has been shown to you. And weight loss intervention is very, very crucial. The target is just reduction in 5 to 10% weight loss, and good high fiber diet, and it makes a lot of difference by using aerobics and making the improve in FRC, these children better managed. So finally, so a good healthy life, change in lifestyle, a high in the fiber diet, and reduction in the weight, rather than just closing our eyes and stepping up the therapy. These measures will make a lot of difference in them. And another important thing is, look at this metformin, and one is associated with 30% reduction in exaggeration, and that is what has been said in up to date 2026. So bariatric surgery is one word about it is a significant improvement in asthma control and lung function, but 60% in reduction in severe exacerbations has been noted. But careful risk benefit evaluation has to be assessed before subjecting any obese child for bariatric surgery. So vaccination is same. Make sure that get the child, pneumococcal vaccine and seasonal influenza vaccine. And to conclude, these 4 points are very important. Make sure that distinguish early allergic and late metabolic asthma in obese. Evaluate best equipment is IOS. It picks up small airway disease much earlier compared to spirometry, and even you can do it in a smaller age children. And treat comorbidities, because invariably they are associated, especially obstructive sleep apnea, GERD, and insulin resistance, and focus mainly on weight reduction. Ultimately, that is the disease modifier rather than our stepping up therapy. And be vigilant because there is a surge in, and make sure that whoever comes with asthma in your clinic, always look at their BMI and try to fit whether they are falling into obese children. Thank you very much for your patient hearing.
That was indeed a brilliant talk, Dr. Kalpana. You've shown us the entire spectrum and what to do and the physiology and the pathology. So it was a brilliant talk because it was something novel and something that we all stood to learn. I'll do a quick summary, right, Manjunath? That's the responsibility.
Yes, madam. Yes,
So
yes.
I'll take a minute per your 10 minutes and see what best, because many may have joined late and they were such great talks that the highlight points. So Indu came in first and she spoke on difficult to treat asthma and biologics. And she very rightly said that before we jump into any exotic treatment, we have to make sure that the diagnosis is asthma and the technique and adherence and the triggers are all addressed. Then she said that under fives, we rarely ever need biologics and it doesn't come in the highest step of treatment too. In adolescent and adults and adolescent, and in 6 to 11 years, it's there in step 5. Then she said a very important thing that generally it is there in where there are associated type 2 comorbids, and this is what has come in GINA 2026, is that you need to consider it only when it is there in you have an associated type 2 comorbid. And then she said that the severe group is only 3 to 10%. GINA today has given us that it's about 3.7% who are actually severe asthmatics. And then she discussed a case and told us how they had given everything and told us about omalizumab and mepolizumab. And of course, the biologics to look out for is probably the TSLP, the tezalinumab. Okay, and then of course the Indian few studies are all retrospective. We definitely need multicentric Indian data. So that was what she told us in her talk. And if there is time for thing, I will ask her something very pertinent to the biologics. Then Dr. Chuk approached the talk brilliantly. He just went on to respiratory support and how to do continued aerosol support. He, of course, discussed it with the case and he asked something that we always say, never sedate, never sedate. But then he says, if you're in the ICU and you can intubate, then you should not fear sedation because it will reduce the oxygen requirement and the work of breathing. Now, people who work in ICU and everybody actually wants to know the management of, children in acute severe asthma. And he says ketamine infusion is what we should use. And then he took us through where HFNC, where NIV, and where mechanical ventilation. And he told a very, very important thing that the hallmark for him to get onto mechanical ventilation is when the child is exhausted. He says that is a wake up. And of course, something very, very important that he told us is that continued aerosol support should be done. It is just not, keeping the airways patent. The aerosol has to go on. And he showed us beautifully in his setup as to how it is done. And the GINA 2026 says you need to do spirometry, and which he showed us that except for in life-threatening situation, we can do spirometry even in severe acute flare-up. So that was talked to. And then we had that all that wheezes is not asthma. And of course, told us about what is typical wheeze, what is atypical wheeze. There was a lot of leaning towards as to what are wheezes in asthma. And he told us the variability, which is seasonal, diurnal, and the importance of proper history taking, that we don't listen, so we don't know. But a very important point that Dr. Subramania made is that, is it wheeze at all? Sometimes we are treating for something else, but actually it's a stridor when you're hearing. So you need to actually know that, because if it's a stridor, then it is all large airways and it is nothing to do with the smaller airways. And the earlier the onset of wheeze, the less likelihood of it being asthma. And then he also told us as to how infection can be a trigger, and how, when the wheeze comes on, and that is the way to know that is it an asthma related, or is it a viral infection which is causing wheeze a little later. And um, and again, a very important point that Dr. Subramania said, that asthma wheeze rarely comes without any cough. That's a very, very important point for everybody to know. And a quick response to bronchodilator is also a hallmark, and a trial of therapy with ICS or oral steroids also tells us. And then he said, if a child is having failure to thrive, is sick and is febrile, there's clubbing, or there is localization in examination which can be subtle or obvious, that's an atypical visa. And so you have to have a good approach, and only then, and he showed us a very sweet slide on how to approach a child. So this is, of course, something that we've heard repeatedly, but it was a good recap for everybody. Then comes Shishir with a very well worked out talk on step down. And he gave us, why do we need to step down? You need to step down because you need to minimize side effects. And at the lowest dose, if you can control, why must you give high dose? And of course, it minimizes cost. And you only step down when you've achieved good control over 2 to 3 months. And when the lung functions after some time reaches a plateau, and you can't say, okay, I'm giving more and it's going to get better and better and better. No, after some time it's plateaued and you cannot. But you have to have a suitable time for it. And he told us, about situations where you should not. And there are certain risk factors where you have to be extremely, extremely careful when you step down. That is, if this child has been in in an emergency room in the last 12 months, and a low baseline of FEV1 60 has become 65 in the Neogena, and a high sputum eosinophil. And he said that when you step down, you definitely need to discuss the asthma action plan, and it's very much individualized. Like, one size just doesn't fit all in treatment, one size doesn't fit all even when you step down. And you step down ICS 50%. That's again a GINA recommendation. And spirometry should ideally be done. And when we stop completely, you have to tell them what is the appropriate reliever for the child, and that should be discussed when one is stepping down or stopping. However, in adolescent and adult, we don't stop the ICS, and now there is just no concept of only ICS. It is track 1, which is ICS and LABA. So your lowest dose would be the lowest dose of formoterol budesonide. Now, that brings me to the last talk. I think this was a lot that we all learned. And I was right when I said FOT is really, got Dr. Kalpanavar so interested in it, and he shared it with us. And again, that younger the age, more is the risk. And 9% of urban children are obese, and 4% of rural children are obese. And he told us beautifully that how does obesity impact? It's mechanical because it lowers the FRC. It's structural, which was a very good thing to know, because the lung parenchyma increases, but the airway doesn't increase. And there is where you have the dysynapsis. Then the immunological, where he told us about the IL-6, and also that it's a systemic inflammatory. I mean, it's a systemic inflammatory disease. An immunological shift, which he told us that there is Th1 dominance, and it's an oxidative stress. That's why you may not have obese asthmatic responding to our ICS or ICS LABA. And waist circumference, he told us, is a better marker than your BMI. And He, of course, said that spirometry is not such an excellent tool in an obese asthmatic because you don't see the reversibility so well. And he's already told us that that's because of the metabolic thing of the parenchyma increasing and not the airway. And he says in pheno, the resistance and the reactants, they both go down and it kind of shows us more. And again, a very, very important thing that he told us that obesity and oversay can go hand in hand. And is oversay the cause or the effect? Is a lot of work going around, and we mustn't forget the psychological impact that children with obesity have. And we know stress itself is again another trigger. And he, of course, told us about the steps, about higher doses of ICS LABA, biologics, exercise, diet. And he showed us that up to date is that a GLP-1A can be used. GINA 2026 today says is that in obesity and also adolescent with children, GLP-1A is can be used and should be used, because it's easier to say that diet and exercise. Those of us who have obese people around us, you know that it really, really doesn't work because of the systemic inflammation. I think that brings me to the end of your 5 talks. And I think it was such a thrill for me to be able to listen. And because I had to make these notes, I was all ears and listening on. And if time permits, I can ask one question each to each one of them. Indu, first one to you. Do you use biologics? Now, a real life scenario.
The case which I've just mentioned, which I mentioned in my in the presentation, is the child where we are going to start biologics the
Okay.
coming week. But by and large, the number of children where we use biologics are very, very few.
Okay. But
And
how
in
old
fact,
was your child?
she's 6 years old.
Okay, so she's kind of reached
Yeah.
from the 4.5 that you showed the presentation on
Yeah.
to niching. Now, I want to ask you another very important question. Biologics are very expensive. So whether it is omalizumab, I would think is what you are planning to use. So what is your thought on biosimilar omalizumab, which is coming up in a very big way and more affordable?
So I don't have personal experience in that, first of all, and then the data on it is again very little. So even on these biologics which are currently available, the amount of studies in pediatrics is maximum with the regular omalizumab. Mepolizumab, I showed you in my studies, the hardly, the number of patients in which they are studied are 2-digit or 3-digit pediatric patients. So I think it will take time before we can even think of using biosimilars. At this point of time, what is there in our basket is only omalizumab, and dupilumab is there for a few patients, especially those who have severe eczema. I have one patient who is on dupilumab who gets it from outside because he has got terrible eczema, and and plus he has severe uncontrolled asthma. So I have one child on dupilumab as well. So I think we are very few, and that is a bigger child. He's about 14 years old. So I think we have very small things in our basket at this point of time.
So the GINA 2026 actually mentions the biosimilar that, they are, one of the reason is that it is so prohibited. So that is why, because we do have some allergists in our city who are using it for a very severe atopic dermatitis, and they are getting excellent results. And omalizumab biosimilar is available. And I heard one of the allergy chapter talks where this lady had humongous things. So maybe, now that we are opening our mind to a possibility of using, we should think. I think, Dr. Chug, I actually have nothing really to ask you, except that GINA 26 in today's document says that spirometry should be done in every, which you also, when we discussed, you very beautifully mentioned it there, that this is a stage that it can be done. And for those of us who are listening on, there is dramatic changes in flare up. So please look up the GINA 2026 guidelines for it, because we'll have to all change ours. Then Subbu,
I've already started looking at it.
yeah. So it is. We have to change all ours
Yeah, it's been
under
released,
5,
so I
and
have
the
it.
thing, the four pathways. Uh, um, Subbu, I think yours was a talk. The atypical visas and all that visas is not asthma, is something that we've heard and is something that people are. And you made very pertinent points. So I really have nothing to add to yours or ask you for that matter. Shishir, in the GINA 2026, 6 to 11, the reliever of choice now is anti-inflammatory reliever. So whenever, like you mentioned, that whenever ICS, whenever we need SABA, we need to use ICS. That
It
has
has gone.
gone off completely.
Right.
But it hasn't yet come in the under 5. The under 5 stays pretty much the same. But in the 6 to 11, it's no more that.
Yeah.
But otherwise, I think, and
As you
another,
are aware, I'm very much fond of anti-inflammatory liver for many
yeah,
years.
you're
Even it
very fond of,
appeared before it
you're
appeared in GINA. So
but formoterol budesonide,
yes.
unfortunately, still is
Yeah.
not cleared for little babies whom you're
Yeah.
fond
Yeah.
of writing. So we
Yeah.
still be guarded on that. Another thing is that when you said, it was a very beautiful thing to hear that the month of May, the World Asthma Day, is when we step down. Yes, we do our spirometries because it's school vacation, but I wonder if you all have seen, but there we saw when the summer hit us a lot of flare up of asthma. So summer is now no more such a wonderful season. Dr. Chuk, did you see that?
If you come to my ICU today or you come to my OPD, all patients are asthma.
Absolutely.
This is the season when there is threshing of the crops that have been cut in Haryana around my place. Everybody who ever had asthma is having exacerbation and a flare up these days. So it probably goes from area to area and
It is
geographical area.
specific trigger induced in the north, northern
Even in
states.
Pune this time we saw a lot because of very low wind velocity, and and with the trees flowering with the pollen, because the pollen counts were also high. So it was, so when we said summer, so now with the big thing that Gina has, the climate change and asthma, so extreme of weather. I'm not saying the normal summers that we used to have or the non-summers that we used to have in Pune, but this time our summer was like a North India summer, right? Like nearly 43, 44 degrees.
Yeah.
And
Bernally,
yes,
Bernally, for three things there are no seasons. One is for asthma, and next is for elections, and third is for the war.
true. Okay, and I think Dr. Kalapanawar, you kind of covered it beautifully. It was an eye opener. It was a brilliant talk. But most of all, and again for you, like which you said, the GLP-A1, and you said it's up to date 2026 has come into GINA now, and we see a lot of, and one thing is that the girls around menarche, obesity, they are generally TH1 or TH2 low. So those are very, very difficult to, and there, if we don't control their weight, we actually don't have much in the asthma basket to help them. So that is where GLP.
Actually, the just above that slide, I had a case that I wanted to show because time was right 10 minutes. I actually told Manjunath that I should not exceed, so I stopped there. So I had a case of a girl, and if you see that child, and it is something different, and that's what I was always. It's something, if you see that child, and oh, not able, I think.
I'm sure
Is
we'll see it in one of the future
yeah.
case
That's
presentations.
actually
So I
good
will kind
case.
of, before I hand over to Manjunath, I would request each one of you on World Asthma Day to give your message to the audience, which has been patiently with us for 1.5 hours. I start with you, Indu. We go in the order of your presentation.
My God, I need to think what message to give. If I were to give a message pertaining to my talks, I would say,
No, on asthma. You don't have to stick to your biologics because you've already done a wonderful presentation.
okay, So I would say that asthma should not be a limitation. Limit your asthma. Use anti-inflammatory inhalers for relievers, as for relieving as and also for maintaining, so that you can live a better life. So it should not be a limitation.
Great, super. So we go on to Dr. Chuk.
If an asthmatic comes to us for the first time or been coming to, we must always teach them to learn. The parents should learn to recognize the exacerbation, the flare up. Many times they've been coming to us and then they come in a very bad state, and when they come to my ICU, I feel really sad. I feel somewhere I've failed. That probably we need to do better.
That's wonderful. That's one of our A's of asthma counseling, that you teach them how to recognize an acute flare-up. That's wonderful. Subbu, your turn now. A message?
Yeah. Asthma is a syndromic clinical diagnosis, and every pediatrician know how to diagnose. Absolutely, there is no problem except in too young. Let's not complicate the science too much for them. But if a patient doesn't respond in a month or so, that is when your history taking and evaluation should be 10 times more than what you have done on the first time. That's all that I want to tell them.
Wonderful. Shishir, you?
Yeah, the message is pertaining to my talk that anti-inflammatory reliever is the mainstay, but don't stop it suddenly. Don't stop in few days. Go very gradually and follow up regularly with your consultant. And it's a long-term treatment for going on for months. That should be the message.
Dr. Kalapanawar?
Yeah, my statement is for all the one who is treating the asthma, teach more than what you treat. That's number one. Number two, in near future, obesity should be the prime concern in the slogan of Asthma Day.
That's wonderful. I think before, it's just not the five. We would want to hear what Jayant's message is to the audience, and Manjunath, the convener of today's program, to have the last and the final word. So before that, you, Jayant.
So I think we are commemorating World Asthma Day, and it's one of the fantastic occasions that we had stalwarts coming on our platform. I must appreciate Dr. Barnali's skill of moderating things, and she made it so lively. And I think kudos to her. I think we should give her a round of applause. And I think it was you who kept it interesting. And I think I pat my back because it was my choice.
Thank you.
But of course, everyone, I think Dr. Chuk sir, Indu, Dr. Subbu, as usual, Dr. Kalapanawar, it was really an eye-opener. A lot of new information we received. And Shishir, of course, as always, very methodical, stepwise. And he made it very nice, very simple to understand. So I think I'm pretty sure that all the attending delegates must have got benefited with this particular discussion. And in a way, this is the way how we kind of, update ourselves or enlighten ourselves and look forward to managing our children of asthma in a better way. So every GINA guidelines come, they teach us something. We are looking eagerly forward to get the new guidelines, and we understand more about this particular problem. We learn every new thing. Again, Dr. Indu also mentioned about the limitations, biologicals, but then research is coming up, new things are coming up. I think this was a very fruitful discussion, and thank you on behalf of Iapnrc. I sincerely thank all the faculty speakers for sparing their valuable time and with their excellent scientific contribution for this topic of pediatric asthma. Thanks a lot. Now I request Dr. Manjunath to give a vote of thanks.
I mean, I do not have any words to express my gratitude for all the stalwart faculty here. Now, when Dr. Jayant, the chairperson who called me up and said, arrange for this talk, it was a difficult task for me. So I reached out to Dr. Subramania, Dr. Kalapnavar, everybody whom I could, and then figured out what to be done. And then when I got to know Dr. Banali will be moderating, it just became an icing on the cake. And and at the end of 2 hours...
Very nicely compiled, Dr. Manjunath. Very nice selection of topics. I forgot to mention you. Thank you so much.
So at the end of 2 hours, all I feel is elated. All I feel is learned. All I feel is, thankful to all the people who have participated as the faculty, as the delegate, as the chairperson, everybody here. So it is one of the best days of my life to listen from all the speakers. Thank you. Thank you, Iapnrc, for giving me
I,
this opportunity to
I
be.
will just take a minute of yours. Just continuing with the World Asthma Day activities, we are privileged to listen to Professor Andrew Bush on Thursday at 9:30 p.m. It is day after tomorrow, and he will be talking about severe asthma in pertinence with New GINA guidelines. So please, everyone is requested to attend. I'll share the link tomorrow, and this will be moderated by none other than Professor Varinder Singh, who has been a very close mate of Professor Andrew Bush. So just to extend, he could not spare time today. Otherwise, we would have probably thought of involving him Asthma Day itself. But still, he has agreed to give us a talk, and it will be on Thursday at 9:30 p.m. As usual, Dr. Manjunath will be the convener for that session also. So look forward to having your company for that as well. Thank you very much.
Thank you.
So with this we conclude our session. Thank you everybody, and for all the speakers and the faculty and the delegates to be a part of this Asthma Day, World Asthma Day. Thank you. Have a good
Thank you so much. Thank you for inviting me.
Bye bye. Thank you.
Good
Thank you
night.
for the opportunity. Bye. Good night.
Good night.